Assalamu alaikum. My name is Ushnarif Siddiqui. My roll number is BP1650246, and the drug which is given to me it is Lopinavir by the pharmacy practice assignment. Lopinavir is an antiretroviral protease inhibitor used in the combination with other antiretrovirals in the treatment of HIV-1 infection. It is its main indication and rational use. Lopinavir is marketed and administered exclusively in the combination with ritonavir. This combination first marketed by Abbott under the brand name Caletra in 2000. Lopinavir sold under the brand name Caletra among others. It is a fixed dose combination antiretroviral medication for the treatment and prevention of HIV/AIDS. It combines Lopinavir with a low dose of ritonavir. It is generally recommended for use with other antiretrovirals. It may be used for prevention of a needle stick injury or other potential exposure. It's taken by mouth as a tablet, capsule, or a solution. Now, what is its mechanism of action is that Lopinavir is a peptidomimetic molecule. It contains a hydroxythylene scaffold that mimics the peptide linkage typically targeted by the HIV-1 protease enzyme, but which itself cannot be cleaved, and thus preventing the activity of HIV protease. But which itself cannot be by preventing HIV protease activity, and thus the proteolysis of GAG polyprotein Lopinavir results in the production of immature non-infectious viral particles. Its side effects are not major side effects but like diarrhea, headache, nausea, vomiting, stomach upset, drowsiness, dizziness, and a bad taste in the mouth. Trouble sleeping may occur. If any of these effects persist or worsen, tell your doctor or pharmacist promptly. Available dose we have for adults and pediatrics. For adults we have 400 mg per 100 mg per oral Q12R, or we can give 800 mg per 200 mg per oral Q day in patients with less than 3 Lopinavir resistance associated substitutions. For pediatric we have per oral solution like 300 mg per 75 mg per meter square, or 16 mg per 4 mg LPV per kilogram per oral Q12 hourly. Use of 300 mg per 75 mg LPV per meter square in infants aged less than 6 months associated with lower LPV trough levels than those found in the adults. These are the basic available doses for Lopinavir. Dose adjustment, dose we can adjust for in pregnant women, administer 400 per 100 mg of twice daily in pregnant patients with no documented Lopinavir associated resistance substitutions. Once daily dosing not recommended in pregnancy. Avoid use of oral solution during pregnancy due to ethanol content. We have certain alternative drug choices, if you are not giving Lopinavir, so you can give other drugs which are also the protease inhibitors. So Nelfinavir is also the same function of action, mechanism of action as Lopinavir. So Nelfinavir is also an antiretroviral drug which is also used in the treatment of human immunodeficiency virus. It is also belongs to the same class, which is protease inhibitor. Like other protease inhibitor, it's always used in combination with other antiretroviral drugs. It works by decreasing the amount of HIV in the blood. Other than that, we have Delaverdin. Delaverdin is a non-nucleoside reverse transcriptase inhibitor marketed by VIV Healthcare. It is used as part of highly active antiretroviral therapy for the treatment of HIV type 1. It is presented as mesylate. It is also used along with the other medications to treat the HIV. Delaverdin also it works by decreasing the amount of HIV in the blood. For the toxicity, Lopinavir can cause transient and usually asymptomatic elevations in serum aminotransferase levels and rarely clinically apparent acute liver injury in HPV or HCV co-infected patients. Highly active antiretroviral therapy with Lopinavir may result of an exacerbation of the underlying chronic hepatitis B or C. As Lopinavir is only available in combination with ritonavir, experience with acute Lopinavir overdose in isolation is limited. The risk related to overdose appears more pronounced in pediatric patients. One case report detail a fatal cardiogenic shock in a 2.1 kg infant following an approximately 10-fold overdose of Calatra oral solution. While other reported reactions to overdose in infants includes complete AV block, cardiomyopathy, lactate acidosis, and acute renal failure. Drug-drug interactions, they can have certain drug-drug interactions, like for example Emprinavir. If you are giving it the Emprinavir, the serum concentration of Lopinavir can be decreased when it is combined with Emprinavir. Caripuride, the risk of severity of QTc prolongation can be increased when Lopinavir is combined with caripuride. So there are also pros and cons of drug-drug interactions. Antidote for Lopinavir, there is no antidote for Lopinavir overdose. Actually, we have certain available brands, like for example we have high risk LR tablet 60s, which company is Aurobindo, and price is 2778. Lopimune tablet 60, which is company is Cipla, and it is of 2200, and it is also of 2700. Amletra tablet, which is Mcure Pharma, it says 2874. But we are using, as we have already discussed, the Calatra. Calatra is very is available as a generic medication and may be significantly cheaper compared to the brand version. Unless there is a specific reason you need the brand, the generic medication will be a better value for even more savings. Use a good RX coupon, pay just retail price. Calatra can be taken once or twice daily. Tablets can be taken with food or without food. It can be used in pregnancy as long as taken. No Calatra Lopinavir must be swallowed whole. They can be cut, chewed, or crushed. If you have a hard time swallowing the tablets, ask your provider about the solution. But the cheapest is we have is Calatra, which is the most preferred brand for Lopinavir. The case study we have of HIV infection, it is that a 26-year-old homosexual man was diagnosed with HIV positive when he presented with fever, rash, myalgia, and lymphadenopathy. The test results of HIV-1 antibody antigen were consistent with acute seroconversion. The CD4 count was 138 cells per microliter. 11% serology tests for hepatitis B, C, and syphilis were negative. Soap notes. Subjective. In subjective we have also patient age. The male gender is homosexual. Patient जो है वो it is diagnosed with HIV-1 positive. Also he have fever, rash, myalgia, and lymphadenopathy. The objects we have we have the vitals in the object, like test results for HIV antibody were consistent with acute seroconversion. The CD4 count was 138 cells per microliter. Or serology test for hepatitis B and C and syphilis were negative. Now the assessment is that firstly he is diagnosed with HIV. So now as the patient is diagnosed with HIV-1 positive, then a genotypic test would be indicated in this setting. Like for genes we have to do this test to suggest which antiretroviral therapy is recommended or not, and which drugs we are going to give in this. So genotypic testing may detect mutations that signal the presence of resistance without having significant impact on the virus phenotype. Now we are going to suggest the antiretrovirals therapy. Now, to date, there is no evidence of long-term clinical benefit to support the routine use of antiretroviral therapy in primary infection. It has been proposed that early treatment may be important in preserving HIV-1 specific immune responses. Individual who presents with several or prolonged symptoms may benefit from therapy, although the optimal duration of therapy remains to be determined. The potential benefits of early treatment should be balanced against the possible problems of drug toxicity, compliance, and emergence of resistance. Trials are currently underway to assess treatment and of early HIV infections, and whenever possible, patients should be offered the opportunity to enter these trials. For this, when we have done the test, we will recommend the patient that the treatment should be started after diagnosis and genotypic resistance test with abacavir 600 mg once daily, tenofovir disoproxil fumarate 245 mg once daily, and ritonavir boosted lopinavir, which is 400 per 100 twice daily. As we give the retroviral therapy like in a regimen form, so abacavir is we are suggesting it because it is also antiviral nucleoside reverse transcriptase inhibitor, which is used in combinations with antiretrovirals. Also, it is also for the HIV, and it is a very powerful nucleoside analog reverse transcript inhibitor, which is used to treat HIV and AIDS. Tenofovir disoproxil fumarate, basically it is not a cure for HIV infection, but we will always give this combination with other HIV medicines. So it is also for HIV, and it is also NRTI, and belongs to the class that nucleotide reverse transcriptase inhibitors. There are many factors that may affect drug levels, including genetic determinants of drug metabolism, effects of food on drug absorption, renal or hepatic impairment, drug interactions including interaction with herbal and other supplements, and other host related factors such as age, body weight, and pregnancy. So after all these, we must check the therapeutic drug monitoring result, that the plasma level of LPV are enough to inhibit the virus or not. After that, we have given this regimen, but we will again test, like for the genotypic test you have to again do that test to know if that these regimens are working or not, so that we can change these regimens if it is resistance or not to that HIV. So we will change these regimen further. That's all. These are the references which I have taken the case study and also the material. Thank you.